I have the honor, I'm David Johnson, and I'm on the board member. I'm a board member for the Delta Dental of Iowa Foundation. I'm also Dean of the College of Dentistry at the University of Iowa, and it's my honor really to start the next part of this program on best practices in Iowa, and we have two terrific speakers from very different perspectives. One is Dr. Howard Cowen and Mr. Dan March, and they're going to give a panel on the overview of mobile dental practices currently in place. Dr. Cowen is clinical professor, and you can ask just about anyone, and they'll say, who would you send your loved one to if they had this kind of problem? And they'll say Howard Cowen. So anyway, and Mr. March is joining us now from the state of Kansas, where he served delivering many programs and organizing many programs. So we have the professor side, and we have the really community organizer side for this. So with that, I'm going to, and Dr. Cowen is going to start this terrific program off. Thank you very much.
Well, it's amazing how many things are replicated. We had a program as well a number of years ago where we trained, took 4 nursing facilities that we had, and we trained they gave us 2 CNAs, and we trained them in oral health care, gave them a 4-day course, and wanted to see if we could change the outcomes of the oral health care. We did not publish this information, my lacking ability to do that, but this was part of the dental school and the nursing school getting together, and the outcome, I'll tell you what the final outcome is, that the turnover rate was the problem. Although these 2 CNAs from all 4 of these homes were very dedicated, within 6 months, all 8 CNAs were gone. And so then the process would need to be started again. So although this is it's a wonderful thought, it does have its problems, and there has to be some part of that makes it sustainable, I think, which is difficult. The other question was asked previously about giving an effective in-service. We've done the same thing for years with the number of homes that we go to, and what I tell the staff is if I'm giving an in-service is bring me your toughest patient. Who do you have? Who do you think that I can't brush their teeth? If you have someone out there that bites, someone out there that you think that I can't brush their teeth, let's go do it. That's basically what I can say. I don't know if you want to take that on necessarily, but because there are people that do bite, and not to say that I haven't gotten bitten before, many times, but those are things that need to be addressed. I know that we've taken people's teeth out before, and the nursing staff was just clapping joyously because she had sent a couple people to the hospital in her biting escapades. So these stories are ongoing. They're the same, it seems, no matter where you are or what we're doing. The question is, how do we get through all this and have all of our experiences turn out to be something that we can further this whole process. So I'll go back to the beginning. Okay, so we're going to look at this from a different perspective now. We're going to look at the education of the dentists. How do we support, how are we going to be a part of this process? And I'm happy and proud to be a part of this process from the University of Iowa College of Dentistry, which I've been there a number of years. And we have an incredible geriatric education at the university. So the education at the College of Dentistry for our dental students starts in their 3rd year. We have a didactic course that introduces the study of aging with an emphasis on clinical decision-making, management of the medically, physically, and intellectually disabled adult. That course is directed by Dr. Ron Edinger, who's sitting up in front here. And in the 4th year, we have the Geriatric and Special Needs Program, which is a clinical and didactic course. And I'll talk more about that. That's going to be the emphasis of my talk today. That program was initially started in 1978. Dr. Ron Edinger, who's here as well, Dr. Jim Beck got a HRSA grant and started this program, and it has expanded dramatically thanks to his insight and foresight into the future. Geriatric and Special Needs Certificate Program now we have as well for graduate students. We've had this in the past through grants. Now we have it established through the university, so we also have a graduate program. Hopefully we'll be able to bring people who are more specialized and can provide this care. So the program that I'm going to talk about mainly is the Geriatric and Special Needs Program, which is a program, it's an extramural program for the fourth-year dental students. It's composed of two clinics, which is the Geriatric and Special Needs Clinic and the Geriatric Mobile Dental Unit. So this program then, through these two programs, tries to allow a dental student to see what it's like to treat frail elderly that can come to your office, as well as the functionally dependent elderly in the nursing facility. It's a 5-week rotation. Approximately 70 to 80% of the senior students go through this rotation. It provides them with 8 to 10 full days of clinical experience in the nursing facility and about 12 to 14 days of clinical experience in the Geriatric and Special Needs Clinic, as well as 4 half-day seminars with case study analysis and case discussions. So like Dr. Helgeson's program, we also received the ADA Award for Geriatric Excellence, and I think that this is a model of care in terms of education that is unsurpassed in the United States. Populations that we serve at this point in time, we go to 10 nursing homes surrounding the Iowa City area. At one point in time, we had gone to 26 nursing facilities, and so we had to decide how we were going to continue to do that. Our model of care is to provide total comprehensive care to the residents in the facility. So when people talk about the type of care that they're providing, whether it's a screening, whether it's an exam, our model provides comprehensive care, meaning when we go into that facility, like Dr. Helgeson, we provide everything. We do the extractions, the dentures, the partials, all the fillings that need to be done. About the only thing that I can say that we don't do is we don't place implants. Other than that, we'll support the implants, but that's about the only thing we don't do. Root canals, bridges, whatever the patient may need that's in their best interest is what we're going to provide. With that in mind, having 26 homes and the needs of all those people, it was becoming a point where by the time we got back to these homes, we were just doing essentially episodic care. So we decided to get a good cohort of 10 homes and provide comprehensive care for this group of 10 homes. We also provide homebound care for hospice patients and also homebound elderly patients. Thanks to the special care clinic at what used to be called the Special Care Clinic at the University of Iowa, started in 1985, again, with a thought process from Dr. Ettinger and others that the Geriatric Mobile Unit was great. We were going to long-term care, but this is really a difficult arena for 23, 24-year-old adults to try and provide care for this very difficult medically, physically, cognitively compromised population. So we thought to complement that, it would be nice to have something where the patients were difficult, but maybe not as difficult, to complement that so that they could understand that they could treat some level of these patients as well in their office. So we started with the Special Care Clinic. It was, a 2-chair little clinic when we started in a little part of the dental school. We had volunteer faculty, and thanks to the progression and the success of the program, we've made it a long ways. Populations that are served by us are the medically compromised elderly, frail and functionally dependent, medically, physically, and intellectually disabled adults, homeless, indigent of the area around us, and anxious and phobic patients. Funding sources that we have: private pay pays for about 65% of our funding sources, Title 19 about 30%, and we also have some partnerships with various nonprofit organizations, United Way of Johnson County and other charitable organizations who give us money for care of patients. Again, thanks to the Delta Dental of Iowa Foundation and a generous donation, we have renamed our new clinic in the dental school, which has windows, and I have to say it's right now the only clinic in the school that has windows. So we have gone from a 2-chair clinic to the premier clinic, I think, in the new edition of the dental school. This is the waiting room. As you come through, we actually have a waiting room that is that we share with the Department of Endodontics. We thought that that might be a difficult sharing point at one point in time, but it's turned out to be very, very manageable. This is actually a private operatory that one of our fellows is working in. They're nice, very large operatories, 2 windows on this side. It's a very nice space. This is another one of our fellows. We have 2 geriatric fellows at the present time working in an operatory. We also have access in one operatory to wheelchair lift. So a patient who can't get out of their wheelchair has a difficult transfer. We leave them in the wheelchair, take them back. There's no movement whatsoever, and we can perform most any procedures that we want. Again, I'm a proponent for absolutely not leaving a patient in a wheelchair if at all possible. I believe that although we can get things done, the practitioner, if they're going to stay a long time in the practice of trying to treat these patients, that if you're not comfortable as a practitioner, then you're not going to be doing it very long. Your back is going to go out twisting and turning and making these difficult moves is very hard. So if we can make a transfer, we're going to make a transfer. The couple minutes it takes to do that is going to be far more beneficial to the practitioner over a long period of time. This is what the clinic looks like from a direct view. We have 12 operatories, 10 of them facing. Most of them are semi-private, as you can see. This is our own lab we have. This is a big deal for us. Every unit has radiograph and computerized technology. Again, this is the very nice operatory as well. We have all the systems that we need just in case we have an emergency. We also have the oral surgery department to take care of that if we need to. This is the other aspect of our program, which actually started the whole program. The Geriatric Mobile Dental Unit. This is the van that you see here. This van is, you see this, and this is what you get. It is a van that carries things around. And the model, as Dr. Helgeson mentioned before, is one in which if you're going to provide care to these residents, you're going to have to do it in the home. If it's going to be effective on the cognitively impaired, the dementia patient, any patient who needs to go to the restroom, whatever the needs are, changing their environment, changing the weather, whatever it may be, is going to make things very difficult. If we're going to get things done, we're going to have to work with the people inside to get the best results. But we do sterilize our own equipment, pour up models, do our sterilizing. Radiographs, we're still in the Stone Ages. At this point, we still have analog radiographs on our mobile unit. We still go to very rural areas. We do not have internet access to everywhere. So digital radiographs, although it's hopefully coming very soon, has been very difficult to integrate into our practice. This is a typical nursing home that we go to. Again, we go to 10 nursing facilities. These are very rural facilities. We do go to a few high-tech urban facilities in Iowa City, 60,000, 75,000 population. So we're not talking about urban area large homes. We're talking relatively small rural homes, and most of these homes, we're not talking southeast Iowa where it's very difficult to get anybody to come to, but even within our range, it's very difficult to get care in these facilities. This is a setup that you see inside of a facility, okay? So this is one chair in a room inside a facility with mobile equipment, okay? I should say this is portable equipment because some people use that interchangeably. So we have a portable chair, we have portable units, we have different kinds of units to show the students what kind of different units they can use. Anywhere from a unit, and as you can see in the background here, is a one-stage unit. The same thing here. Now we have taken advantage of this position where we're in a closet. You can see that bar across the top. That's a closet we took the doors off of because we didn't have enough space. So we talk about a space issue. Was there ever a space issue? That question I just nearly choked on. That is always a problem. We are never in the same area anytime we go to any of the homes. And we have standard contracts with all these homes. We never know where we're going to be. And many times it turns out to be, okay, are you going to give us the place or are we just not going to come this time? And then they finally decide that they'll make a space. So it gets to that point many times. Okay? So again, we're providing all kinds of care with different kinds of systems. We have a fiber optic light here. We have different kinds of lighting systems. We have one dental assistant who manages all the people that we see, portable x-ray machine, as you can see here, as well as the Nomad that was talked about earlier. The Nomad in Iowa, yes, we do have special considerations that we have to abide by, but we can use it in the nursing facilities. And we have to take a test to make sure we know how to use it. Every practitioner has to take their basic test, but it works fantastic. It works as good as any other radiograph machine, and we get excellent results with it. The level of patients that we have, again, this is another patient's room that you see, just different facilities. We have 4 chairs running at any one time. So we take 4 dental students with us. So at any one time, we have 1 faculty, 1 dental assistant, maybe sometimes 2, but we have 4 chairs running at any one time. Okay, denture adjustments, sometimes we have to go bedside, so we'll provide all the care that's needed no matter where it is. If we have to go to bedside and provide the care in the bed, we'll do the best we can there. We never know the patients, are they gonna have a good day, a bad day? We all know that nursing facility patients, long-term care patients, you never know what kind of day they're having. So we have to take advantage of that and if they can't come some days, we'll get them another day. Some days the verbal abuse is very difficult, other days, you know, you might get some physical violence, but we get through all that because they're not the same every day. They have different days, they have good days, and they have bad days. And some days they just don't want to be seen, and we'll have to deal with that and do the best that we can. We also, though, have a dental hygienist who has a 6-month recall program. So as we rotate through the 10 homes that we go through, we have a hygienist that not only performs the cleanings at the time that we're there, but as we rotate through, she also goes through the back side, and every 6 months, she continues to clean people's teeth. So even though we are only providing the comprehensive care, about every 18 months, she's going around on the back side of us and getting prophies for all the residents every 6 months. If she has concerns from her point of view, then she'll relay those to us, and we will either take care of it at the facility itself, or we will have them referred to the Geriatric and Special Needs Clinic at the College of Dentistry. So again, a very portable system for the hygienist. This is how things actually started out. This is not the unit that she has now, but we started out with nothing. 30 years ago, there wasn't such a thing as portable equipment. We had a gentleman, Dr. Glenn, who built our own box and put our generator inside the box. And that's what we took around when things started. So there wasn't such a thing. The beautiful equipment that Dr. Helgeson has is fantastic. We don't have quite that level of equipment, but we don't have the space for any of that either. So, but everybody's got a different model. This model shows the students as they go through that they can provide a good care. I can't tell you how many times we've been in showers. Here you can see us in a shower. There's one home we go to that they just built a brand new facility. We asked them, can you just, give us a room that could be dedicated, not all the time, but whenever we come. No, so we have a dining room on one side, and across the hall we're in a shower. Brand new facility. Great. Yeah. So what are we up against, and what are we talking about? I know you probably have all seen this, but this is the mouth that we see every day. This is the mouth that we see every day. Now, we have lots of things that have been talked about. We have, how do you clean these people's mouths? What are you going to do for these people? Some of this stuff is, you can't even comprehend the level of difficulty that it is. We're talking about people who have now maintained their teeth. I don't know, almost 1 billion teeth now, is that what you said? Okay, now we have 1 billion teeth out there. Before, 20 years ago, we had, what? 100 million. So now we have 1 billion. Now, what do we do with 1 billion teeth with people that can't take care of them? So when I was doing this 30 years ago, life was not so hard compared to what it is now. Now people have teeth, they've maintained them their whole life. What do they do now that they can't take care of them? What happens to them? And this is very difficult to see, and it's very difficult for their loved ones to see, to not understand what's happened. Mom and dad always took such good care of their mouth. Now look, why is it like this? Why is this happening? So I'm not going to, say why it's happening necessarily. I have my own understanding of why it's happening, but there's lots of problems, lots of different angles. But how do you take care of this? What are the decision-making processes that go through this? A person who's wearing dentures and can't wear them anymore, how is a nursing aide or a RN going to look in the mouth and see something on the back of a posterior ridge of a denture and see that something's wrong? Why the patient's spitting their denture out all the time and won't wear it anymore? How are they going to see that? So again, working as a team, the types of things that happen, the disease process that happen with ill-fitting prostheses, with teeth that are now becoming very difficult to deal with. This is a poor lady who relined her own dentures. This always just amazes me. It was like a tree where it was cut in half and we could count the layers. And I think we ended up with 17 layers of relines on this poor lady. And the sad thing is she didn't want us to do anything with her denture. And of course, the dentures were sitting down, so her upper teeth were way down. They were almost right on the ridge of her lower teeth. And as we were in this facility, and these are facilities that we go to on a regular basis, this poor lady was sent to the hospital on an emergency basis because she had an oropharyngeal candida infection that nearly killed her, and they sent her back to the facility with psych meds because they thought she was crazy. And it just so happened that we happened to be there and see the lady and realize what the problem was. So they're very difficult. I mean, these are not easy things. I don't want to say this in a negative way, but these poor cognitively impaired patients who can't take care of themselves, I don't know any other analogy, but we all have a pet that we love, and you want that pet to tell you what's wrong. Oh, please tell me what's wrong. I know you're not feeling good, and it's you just want the same thing from these people, and they can't tell you, and it's very hard. You really have to understand the patient to try and get the nursing staff. Maybe there's a lot of times there's one nursing staff that gets along with the patient or understands the patient better than others, to use those people to your advantage. These are all things that we've all learned how to do, and they're very difficult, but we try and teach our students as well the difficulty and the side effects and the oral health effects of how that affects the patient systemically. Thank goodness for the new research that's coming out to show the oral health and systemic associations that are making our usefulness in our job easier to relay to the medical profession and have them understand. We also then go out and do periodic types of care. So we call this our black box because it used to be black, but now it's not black anymore. But this is our black box, and what we have is just essentially a fishing tackle box that has everything we can stick into it possibly in there. So I've got this in my car. It's always in my car. I've got a Dremel in here so I can work on dentures. I can extract directly any tooth. I can do relines with this thing. The only thing I can't do is any restorative work. I can take a spoon, take some decay out, and put a glass ionomer in, because I've got hand-mixed glass ionomer. There's a lot of things I can do with a simple box. I never take that box out of my car. Yeah, so again, adjusting dentures for ulcers. What do you do for people with root tips? All these things are very difficult candida infections that are something that could be done on a regular basis. Hopefully just to make the quality of life good for some of these people. But we all know that I just had some talk with some people over the noon hour. Why do people, what's the joy of being in a nursing facility? Who wants to be there? What's your happiness in the day? There's not very much, but eating is still one of them for most of those people. And if they can eat without any discomfort, then you've done them some service. As much as we try and do good, and as much as we can try and help all those people, the types of things that we find are still devastating. And I know maybe some of you know this from the dental profession, maybe you don't, but this is a set of x-rays of a person. And we saw this person in 2010, and I just got done seeing this person, and I'm going to show you this because this hurts me personally. We restored this person's dentition completely at this point in time, and this was 2 years ago. And we went back to the facility, and 2 years later, that's what his mouth looked like. There was nothing left in 2 years of no care. I didn't even know what to do. I was so taken back. I felt like I couldn't even call his son and say, this is what we found. We ended up getting all his teeth out in the facility, at least to try and eliminate what was there, and he reacted very well to that. But we're not going to make him dentures. He couldn't respond to that. But this is, things can happen very quickly. And when your parent is there and you see a nice dentition and they're going into the nursing facility and this happens after 2 years, man, that hurts. And I think that the level of pressure from the families now is going to become greater. I hope that part of it makes the impetus from the perspective of the nursing facilities and the profession to get into these homes. When I first started doing this, our consent rate, you got to realize we have to get consent to do all this care. Is this appropriate care for these people in the conditions that they're in? Our consent rate was around 30 to 35% of the people that we felt needed care. Now it's more like 70 to 75%. Okay, so and why is that? It's not because, oh yeah, we know that you're there, we feel comfortable with you. These residents are turning over for mostly because they've passed away, and the family, we're talking to sons and daughters who are 70 years old. They now at least understand that oral health care is part of the care they expect in these facilities. So what have we done? Dr. Kaplan graciously gave us some information that he's taken out of some of the screening forms that we do. We go into the nursing facilities and we screen. This is a brief overview of some of the residents that we screened real quickly out of 10 nursing homes, approximately 600 residents. And from that, we found that of the 600 residents that we screened, the mean age is about 84 years old. Again, 70% female, which is understandable. And among residents there, fully dentate residents were 60%. A little lower than 30% were edentulous. And this is the high end of people. Again, this is not 65 plus, which we gave earlier data for what the edentulous rate was. So these are people that have been around for quite a while. And among those, approximately 58% had a procedure done within 128 days. And most of that was exams, but you can see the other needs that they had. 45% needed a restorative procedure, 24% needed an extraction, and 18% or greater needed a prosthodontic procedure. So what have we done to know that we're doing any good? And our whole purpose here, obviously, is to take care of the people in the facilities that we treat, but our greater purpose is to try and train the dentists that leave to go into their communities and please, feel like at some point in your career you might want to provide this service for some of the residents in the long-term care facilities of your community. So, thanks to the support of our administration, we've been able to keep our program continuing, and this is some of the evaluations that we get back from our students, and a very positive response from their experience. Most of them say that they would recommend this program. Did it increase your knowledge? Yes. And would you think you would have a willingness to treat people who have these kind of compromises? And overwhelmingly, 94% said they would. Dr. Watkins and I sent out a survey to Iowa dentists, of which we got about a 53% response rate, and asked for what their how did the care they provided in nursing facilities as well, or nursing home residents, either in their office or within the facility or within their practice. And 90% of the dentists surveyed said they provided in-office care to nursing home patients. Okay, that's higher than other surveys in other states. 38% only said they provided out-of-care office, and again, that's one of the big barriers as well to the residents themselves, is to try and get care within the facility. Only 10% did not provide care to nursing home patients in their office. This average estimate comes out to about 19% of the population in nursing facilities getting any kind of care at all. Although this is higher than other surveys in other states, it does seem like there's a lot of room for improvement there. Again, so what are the factors associated with in-office care? Mostly they are male dentists do more than female. If they had continuing education or other programs beyond their dental school education, more small community dentists seem to provide that level of care, and dentists who generally accept Medicaid. So we've got more of a public health, generally minded person who is going to go in. This is not easy stuff. It's not going to be all about reimbursement. It doesn't make any difference what the reimbursement is. We're going to increase, we'll probably increase the number of dentists going into facilities and providing this care with an increased reimbursement, but it's not going to be the overwhelming reason why people are going to go in and provide this care. Significant factors associated with out-of-office care, male, greater number of years in practice, post-grad training, continuing education, off-site training, again, community size, use of portable equipment, barriers to care, again, every study seems to find the same thing. Poor daily care. I was talking to a group of people at my table. I said, we go to 10 homes right now who are our core homes. And we have one home that we've gone to that has changed, I think, their model of service. It's a very unique model of service. It's provide the best care we can for our patients. What a unique model. So what has that done for them? That has done for them, that home is so in demand, okay? Our normal home has 50%, about the same as everybody else, Title 19 patients. This home has about 10%. Why? They have a wait list a mile long. Everybody from anywhere around eastern Iowa wants to get into this home. Why? Because their model of care is, let's just provide the best care we can. What a unique way to get patients into your facility. Well, it's working for them, and it's maybe other people ought to look at that model and see if it works for their area as well. Anyway, poor understanding of rules and regulations, emotional demands, I won't deny that. There's a lot of emotional demands out there. But poor daily care is interesting because it's hard to work with facilities and hard to continually work on these people when there's no care. I mean, any dentist out there, any practitioner out there doesn't want to treat people. They want, I mean, they're going to make money, but generally, you know, you don't feel real appreciated when people come in. They never brush their teeth. You brush your teeth, yeah, okay, let's just do the 10 fillings we have to do every time you come in. What the hell? And we keep on doing the same thing. And in the nursing facilities, it's the same thing. Why do we keep on coming in if you're not going to be a part of this team effort? So getting that facility to be on board is really important. So although Iowa needs to, final conclusions, although we need to increase the care of residents in nursing facilities, more care is being provided than many states. Hopefully that's due partly to our education of these people, our dentists coming out of the University of Iowa. And to increase dentist care of nursing home patients, efforts should be made to train and educate dentists, to increase dentist commitment, if we can do that, and increase the legal support for dentists providing nursing home patient care. And just a couple examples. We do have a lot of people coming here. Here I have two examples here of two people from Arizona who actually have had publicity about themselves for providing portable care, at least not the state of Iowa, but they've come out and done that in Arizona. So we have some success with that, and I could probably put up a lot more, but just thought I'd throw out those two. Any questions?